Every time you walk into a clinic, you're stepping into a profoundly lopsided encounter. You probably know the feeling. You sit on that exam table with the crinkly paper beneath you, the door opens, and you are suddenly participating in this complex dynamic where only one person in the room has actually been trained for what is about to happen. Today's deep dive takes us into a piece of source material called Patient Literacy, the Art of the Medical Narrative. Our mission for you today is to unpack exactly why doctor visits so often feel rushed or confusing. We are going to uncover the one specific missing skill that can completely transform how you experience your own healthcare.
The foundational idea we need to establish from the text is that every clinical encounter involves two participants. Only one is prepared for the underlying mechanics of the conversation. Medical students spend years in their training just learning how to interview you. They are taught specific frameworks for asking open questions. They learn how to listen for the underlying meaning beneath the scattered words you might be saying.
That training gap is staggering when you really look at it. The other participant in that room, you walks in with absolutely none of that preparation. You are simply given an appointment time, you show up, and you are expected to perform. The source material highlights specific fields that clinicians are heavily trained in.
Those disciplines include things like motivational interviewing, shared decision-making, and narrative medicine. Those are not just buzzwords. They are entire academic disciplines dedicated entirely to the science and art of extracting information from you. Think about motivational interviewing for a moment. It's not just a doctor asking if you eat vegetables.
Oh, wow.
It is a highly specific psychological framework. It's designed to bypass a patient's natural defensive walls. Doctors go to school for years to learn this kind of psychological judo, allowing them to ask how you feel about your habits in a way that actually yields useful medical information.
I mean, I certainly don't have a degree in narrative medicine. The text we are diving into makes a crucial distinction about this gap. This lack of preparation is not because you're careless, it is not because people are unintelligent, and it is certainly not because they are intentionally evasive.
It is simply because no one has ever taught them how to describe what is wrong. You know something is wrong because you can feel it in your own body. Knowing something is wrong and being able to describe it clearly, logically, and efficiently to a stranger, those are two entirely different skills. Our society only teaches one of those skills.
The reality of your story coming out in pieces is something the text focuses on heavily. You might offer a detail from 3 weeks ago, followed immediately by a detail from yesterday morning.
You might share an observation about your diet that feels incredibly important to you. Then you place it right next to a symptom that actually has zero medical relevance to the current problem.
I think about this like dropping a box of 500 unsorted puzzle pieces on a table in front of a master puzzle solver. You are the one bringing the box. You dump all these fragments of your experience onto the table, and you expect the clinician to assemble the picture perfectly.
You did not bring the pieces with the edges already put together. You didn't separate the blue sky pieces from the green grass pieces. You just brought the chaos of your symptoms and dumped them on the exam table.
The clinician can't tell the important edge pieces from the unimportant middle pieces without asking 5 more questions. They have to sort through the pile you just dropped.
They have to constantly interrupt and redirect. When you tell a story about your stomach hurting and you mention your stress at work, and then you mention a sandwich you ate 3 days ago, the doctor has to do immense cognitive work. They have to figure out which of those details is actually causing the pain.
We are talking about a massive inefficiency here. The emotional frustration of trying to tell a scattered story while someone in a white coat interrupts you is bad enough. The literal mathematical cost of this inefficiency in a clinical setting is what truly derails the visit. This costs healthcare its most limited and valuable resource: time.
The math provided in the text paints a stark picture of this cost. Consider a standard 15-minute clinic visit. That's the reality of modern medicine. If the first 8 minutes of that visit are spent simply reconstructing a basic timeline, the doctor untangling when this started, how it progressed, and what actually happened.
Only 7 minutes remain.
Those remaining 7 minutes are the only time left for what actually requires a medical degree. The doctor only has 7 minutes to reason through what your puzzle pieces mean. 7 minutes to weigh the different treatment options, explain a care plan to you so that you actually understand it, and answer the specific, terrifying questions you were probably afraid to ask when you first walked in the door.
Every single minute spent untangling the basic facts of the narrative is a minute that cannot be spent on the actual reason the visit exists.
The text observes that decades of research have gone into improving the clinician's half of the conversation.
Mm.
Almost no research or training has gone into the patient's half. The author suggests this points to an implicit assumption in healthcare, the assumption that people simply know how to explain what is happening in their own bodies automatically without needing to be taught.
I want to push back on that framing a little bit. Is it really an assumption that patients automatically know how to explain themselves? I look at the history of how medicine operates, and I see a system that has been historically paternalistic. Maybe the system simply treats patients like broken cars at a mechanic. If you are a mechanic, you do not expect the car to tell you what is wrong with the engine. You just plug in a diagnostic machine and treat the car like a passive object. It feels less like an assumption about our natural communication skills and more like a system designed to treat us as passive objects to be examined rather than active participants who need communication tools.
The history of medical practice certainly has paternalistic roots. You bring in the broken machine, the expert uses their tools to diagnose the parts, and the machine has no voice in the process. We have to look at the practical reality of the physician sitting in that room today, though.
I suppose they aren't actively trying to silence people.
The modern doctor is drowning in a system that forces them to see a new patient every 15 minutes. They rely on their own investigative training because that is the only tool they have to get through the day. The source material points us to the practical reality we face today, regardless of the historical root cause.
Organizing a health narrative is a tangible skill.
It is not automatic for anyone. Right now, this skill belongs to no one's curriculum. We can debate the origins of the lopsided dynamic, but the immediate consequence is a 15-minute appointment where 8 minutes are burned trying to figure out a basic timeline.
The diagnosis of this systemic problem leads us directly into a practical solution. The text offers a structured framework that you can apply immediately before your next appointment. It's a way to sort the puzzle pieces before you walk through the clinic doors.
The fix doesn't require you to learn medical vocabulary. You do not need to memorize anatomy or try to diagnose yourself using the internet. The fix only requires structure and a few minutes of preparation before the visit.
The text lays out 6 specific questions.
These questions should be answered beforehand, written down on a phone or a physical note card, rather than reconstructed live under time pressure while someone in a white coat waits for you to speak. The first question is, what changed?
Let's look closely at that first one. What changed? That is fundamentally different from asking what hurts. You might have had a bad lower back for 10 years, but you are at the doctor today because something specifically shifted. Defining that change narrows the focus immediately.
Instead of giving the doctor a 10-year history of back pain, you are telling them that as of Tuesday, the pain started shooting down your left leg. You just handed them a sorted puzzle piece. The second question in the framework is when it started. This addresses the timeline problem we talked about earlier.
People often describe time vaguely when they are put on the spot. They will say a symptom started around the holidays or maybe a few weeks ago. The doctor then has to calculate backwards in their head, asking clarifying questions to pin down a date.
Having a specific date or time frame written down on your note card saves those precious minutes. The third question asks how it has moved since then. Is it better, worse, or the same?
This establishes the trajectory of the problem for the doctor. If you tell them it started on Tuesday and it has steadily gotten worse every single day, that creates a completely different medical urgency than if you say it started on Tuesday, got really bad on Thursday, and is now slightly better.
The trajectory provides immense diagnostic value. The fourth question asks what makes it easier and what makes it harder. These are the triggers. Knowing what exacerbates a symptom or relieves it provides critical clues that clinicians usually have to dig for.
If sitting down makes the back pain worse, but standing up relieves it, that points the doctor toward a very specific structural issue. You are providing the mechanical details they need without them having to interrogate you to find them. The fifth question is where this framework really shifts the dynamic.
How it shows up in an ordinary day.
This specific question bridges the gap between a clinical symptom and human life. It translates abstract pain into a tangible impact that a doctor can actually visualize and act upon. Saying your shoulder hurts at a level 7 is completely abstract. A level 7 means something different to everyone.
Saying you can no longer reach the top shelf to get your coffee mug in the morning is a functional reality. It gives the clinician a clear picture of what you have lost and what they're actually trying to help you get back.
That functional reality anchors the medical narrative. It gives the doctor a baseline to measure your recovery against.
The final question in the framework is, what matters most to say out loud today? This addresses the hidden fears or the underlying anxieties that often get left unsaid. Patients frequently harbor a terrifying thought, like wondering if their headache is actually a brain tumor, but they wait to bring it up until the very end of the appointment
I've heard that called a doorknob confession.
because it happens when the clinician's hand is literally on the doorknob to leave. By writing your biggest fear down beforehand as the final question, you ensure that the primary emotional reason for your visit actually drives the conversation from the beginning.
You take these 6 questions. What changed? When it started? How it has moved since then? What makes it easier or harder? How it shows up in an ordinary day? What matters most to say out loud today? You answer them before you leave your house. You write them down.
The patient who arrives with this organized story is not handing over medical knowledge. They are handing over clarity. Clarity is what turns a rushed, frustrating appointment into a highly useful one.
Every accurate diagnosis begins with a story.
The choice presented by the text is whether that story gets built expensively, fragment by fragment in the examination room while the clock ticks down, or whether it gets carried in already organized and ready to be told.
If organizing your own story changes the dynamic of a doctor's visit this drastically, what other intimidating professional encounters in your life, maybe with a mechanic, a lawyer, or a financial advisor, are actually just communication gaps you could close with a little structured preparation before you walk through the door?